Well, welcome to everyone. Thank you so much for coming. Can everybody hear me okay? Volume's not too much or not enough? Okay. My name is Christina Johnston, and I'll apologize in advance. I have a little laryngitis and I'm just getting over, so my voice is a little raspy. So if I sound a little in and out at times, that's why. I am a neurologist who works for Holland Hospital, and I'm a member of Lakeshore Health Partners in the neurology branch. I've been here for almost 5 years. This is my 5-year anniversary coming up this summer, so time has gone by fast. And since I've been here, I've been practicing as a general neurologist, but part of my job as a neurologist is to see stroke patients. So I am on staff here at the hospital, and when there are stroke patients that come to the hospital, they frequently call me. So my purpose tonight was just to sort of provide a little bit of education that's hopefully at an understandable level, just to kind of make patients and the community aware of how to recognize symptoms of a stroke, what to do if you think you're having a stroke, and sort of what are some of the things that put one at risk for potential strokes. So with that, I'll get started. First of all, I just want to say, too, I have no disclosures, so I always start off with that little bit. So what are some stroke myths that are frequently floating around out there? The first one is that stroke affects the heart, which is entirely false. The other common misconception is that stroke only affects the elderly, which is also not true. Pain is the #1 symptom. That one should just go to bed and sleep it off, and they'll be better when they wake up. If they wake up. Emergent care isn't needed, and that strokes are not preventable. So some facts about stroke is that stroke is actually a brain attack. It has nothing to do with the heart specifically, although it can be associated with heart conditions. Stroke is most common in the elderly, but it can actually occur at any age. It even can happen in infants and neonates, so it is not age discriminatory. Stroke is almost never painful, in fact. It's unusual to have pain associated with a stroke. The most common symptom of pain would be like a headache or something in that regard, but otherwise there's usually no pain associated with it, which I think is why people sometimes ignore their symptoms. Sleep is not recommended when stroke symptoms begin. Absolutely, if you think you're having a stroke, do not go to sleep. Going to sleep is probably the worst thing you can do, because time is incredibly important when we're talking about potential for treatment, and we'll get to that later. Emergency medical treatment as soon as possible is the absolute recommendation, because their strokes are largely preventable, and we can hopefully intervene to limit long-term disability. A little bit of statistical information. Each year, approximately 800,000 new stroke victims in the United States occur. A stroke occurs approximately every 40 seconds in the United States. I thought that was a startling statistic. It's the 5th leading cause of death in the United States. 87% of strokes are ischemic type strokes, and I'll explain what that is a bit later. 80% of strokes are actually preventable. And stroke is the #1 cause of disability in the United States. That is not surprising to me based on what a stroke can do. And approximately $34 billion is spent on stroke care annually. Staggering. So what is a stroke? A common layman term is that it's a brain attack. Everyone knows what a heart attack is, but a stroke could be considered a brain attack. What happens when a stroke occurs is that there is a disruption of blood flow. The circulation to the brain is interrupted in some fashion in one part of the brain. So what happens is that an artery is blocked, or potentially a bleed occurs in the brain, and that disrupts neuronal function. As a result of lack of blood flow or bleeding on the brain or hemorrhage on the brain, that leads to neuronal cell damage and neurological dysfunction. Stroke symptoms will vary depend on where the lack of blood flow or where the hemorrhage occurs in the brain, so the symptoms can vary quite substantially. This is a small illustration there. this is a cross-sectional view of a brain, and these red things going through the brain are the arteries, so the arterial blood flow. And here on this side, you see that there's been a small clot that has blocked the blood flow there. Even there's some plaque along that artery, so it's a narrowed path for the blood to circulate through anyway, and then a blood clot sort of got lodged there and stuck, and now the blood flow can't pass beyond that. So it's like a clog in the pipe, essentially. I already touched a little bit on the two different stroke types. Hemorrhagic strokes are ones that occur less commonly, but can be quite disabling. Here is an illustration of how one of the blood vessels that was in the middle cerebral artery here has ruptured, and there's been blood that just kind of spilled out into the brain parenchyma here. An ischemic stroke is far more common. As I said earlier, about 87% of strokes are typically ischemic strokes. And here what happens is you can see that there's a blockage more proximally in this artery, but this whole region of the brain has been deprived of oxygen or blood flow, and so this whole region of the brain is going to be affected and lose function. And that can have catastrophic consequences. Two types of ischemic stroke are embolic and thrombotic. And I'll go into that a little bit. I have a little illustration that I wanted to show you, so I have to kind of go over here and pull it up.
A stroke may occur when there is an insufficient supply of blood to a brain region, or when damage to the vasculature in a specific brain region causes bleeding into the nervous tissue. In general, there are three types of strokes that occur. They are classified based on the type of vascular defect that causes them. Cerebral hemorrhaging occurs when a vessel bursts, causing bleeding in a region of the cerebral cortex. An embolic stroke occurs when small clots that formed on other parts of the circulatory system occlude cerebral arteries and cut off the blood supply to a part of the cerebral cortex. An ischemic stroke occurs when a narrowing or blockage of cerebral vasculature results in oxygen deprivation in a specific part of the cerebral cortex. The specific functional deficits observed in someone who has suffered a stroke can be correlated with the functions of the damaged cortical region. In a healthy brain, the nerve impulses from the cerebral cortex travel through the brain and cross over to the opposite contralateral side of the body. When a stroke occurs, damage to the cortex is usually unilateral, since information to and from the cortex crosses over the midline. The effects of a stroke on the left side of the brain occur on the right side of the body. A person who has suffered a stroke may experience paralysis that may involve the face, weakness or paralysis of limbs, often limited to one side of the body, loss of sensation that parallels paralysis, difficulty with speech, double vision, loss of vision, dizziness or vomiting, severe headache, loss of consciousness.
So I thought that was a nice brief illustration to kind of explain a little better than I can do, but it's not my own video, so I don't take credit for it. So how do you recognize the signs of when you are concerned that you potentially may be having a stroke? Symptoms are typically very sudden onset. They don't occur over days to weeks. We're talking about symptoms that come on, usually evolve very rapidly within minutes, seconds to minutes, maybe up to an hour or more, but typically that it's a very quick progression of symptoms. It typically starts in one region of the body and will spread. In the video, it indicated or it alluded to that symptoms are typically one side of the body, which is the most common form. It's highly unusual to see symptoms on both sides of the body. So if you feel that you're having symptoms that seem to start in one part of the body and spread to that same side of the body, should raise some alarm. There's a really good acronym that's out there to help help people to understand and remember symptoms of a stroke. The acronym is BEFAST. The B is representative of balance, so any time that there is sudden symptoms of dizziness, unsteadiness, coordination trouble, that's one symptom. Eye movements or sudden loss of vision or inability to see out of one or both eyes could be a symptom. Facial movement will change. It could either develop drooping or profound slurring of the speech, which is the S in FAST. The arm may become weak. Typically the same side of the body that the face is drooping, the arm will become weak as well. Speech will slur, or potentially you have inability to speak at all. Words can come out completely incoherent or unrecognizable. And time is the last part of the acronym, because time is incredibly important. Time is brain, is what we say, because there's a very limited amount of time to get treatment. If you exceed a certain number of hours, once your symptoms begin, there's not much we can do for you, unfortunately. So stroke is a medical emergency, absolutely. This is another sort of representation of how symptoms are typically one side of the body. You can see this little stick guy, his mouth is drooping on one side, his arm is kind of limp, and his leg is also a little limp here, okay? The little black arrow here on the left side of the head is indicating that the right side of the body is disrupted. So that kind of identifies where the problem is. Again, this sort of illustrates that you can have difficulty speaking, loss of feeling on that side of the body can also be a symptom, numbness, sometimes tingling, a funny feeling or a heavy feeling. Weakness is certainly the most common thing that people get alarmed about. But also headaches can be a symptom. Typically that's more common in hemorrhagic forms of stroke. Rarely you'll see it in ischemic strokes as well. Blurred vision or loss of vision, dizziness or balance trouble. So some things we already touched on. So call 911. Do not get in the car and drive to the hospital by yourself. If you're close to the hospital and you have someone to drive you, it has to be quick. But 911 is actually a better, safer way of getting to the hospital. Don't get in the car and drive yourself, because if you continue to get to the hospital, but in the process of getting here, you lose the function of that side of the body, or you lose the ability to see, or, I mean, it can be extremely dangerous. So it's not advisable to drive yourself to the hospital. But do seek emergent medical care. Do not ignore the symptoms. Certainly don't go to sleep, okay? Rapid evaluation is critical because we have a very finite amount of time. 3 hours up to a maximum of 4.5 hours is all that we have to figure out what's wrong, and are you somebody that we can do TPA or other forms of treatment. So TIA is another term that we use when talking about stroke and risk factor for stroke. A TIA is a warning sign for a stroke. It's called a transient ischemic attack, and it's frequently referred to as a mini stroke. That's commonly used in the public. These are symptoms that occur sudden onset like a stroke would, but they don't last for very long and they go away on their own. So without any permanent neurological damage. So this is an illustration of how there's some blockage here in the artery, so the blood is blocked from traveling up to the brain. However, here your body can actually dissolve that clot. There are proteins in our body that will try to dissolve any clots that are circulating, and so you can heal yourself. But if the internal or innate ability to break up the clot doesn't occur, that's when a stroke happens. So approximately 15% of patients with TI will have a stroke within 6 months, and 65% of those occur in the first 30 days. So TIA symptoms, even though you may have had symptoms that seem like they went away after 5 or 10 minutes and it's nothing to worry about, that's a myth as well. It should still raise your concern and urge you to get to the emergency room and get an evaluation, because there's testing that also needs to be done. And if you ignore those symptoms, you could become part of that statistic. So what can be done? What we try to do in the emergency room is to quickly reestablish circulation to that part of the brain that isn't receiving blood flow. So we want to limit permanent neurological tissue damage so that we can preserve function. We want to prevent disability, and we certainly want to prevent death. So in the emergency room, you'll see a physician rather quickly. If there's a patient who's brought to the emergency room via ambulance, in our hospital we say there's a code Z neuro, meaning that person is very highly concerning for stroke, and they get immediate attention. They get taken right back to a bed, a physician, a nurse. Everyone will be there to see you very quickly. We certainly get a picture of your brain as fast as we can, because we want to know, is this potentially a bleeding type of stroke or hemorrhagic stroke, or is this an ischemic stroke? Is there a stroke that we can see, or is there not anything that we can see just yet? We look at arteries, we look at blood work, we look at other information that will help us determine what to do with your treatment. So this is an illustration. This is the CAT scan. of an individual who came, I presume, to the emergency room with a stroke. And here, I don't know if you can see it up here, it's kind of hard to see, but this region of the brain here, this left middle cerebral artery, has suffered a stroke. The grayness to this part of the brain is indicative that this has probably occurred several hours ago, okay? This side of the brain is normal. What the difference is here and how we tell as neurologists and as emergency room physicians is we look at the outer part of the brain here. You can see this, the gyrus of the surface of the brain is still very visible here. This is normal brain. On this side of the brain, you can't see those involutions of the brain surface very well. There's a lot of swelling that has occurred in that part of the brain, and that's also partly how we tell if there's a stroke that's in evolution. Sometimes, in fact, we can even see the clot sitting in an artery on a CAT scan. That's pretty rare, but we do see it sometimes. This is an MRI. So an MRI is going to be much more accurate in determining if one has had a stroke, because sometimes a CAT scan will be normal. A CAT scan can be normal up to 12 hours, sometimes even 24 hours after a stroke occurs. An MRI, however, is much more sensitive. We can get an MRI and see if a person has had a stroke within about 30 minutes, okay? The problem with an MRI is that there's a lot of safety concerns and it takes longer to get the pictures, so CAT scan is our quickest modality that we typically rely on. But here you can see this is the same stroke, but it just lights right up. I mean, anybody can see that. This is an illustration of what's called a CTA. So this is a CAT scan, but really looking more at the arterial blood flow here. So in figure A, you see the artery. This is probably the carotid artery coming up and becoming the middle cerebral artery here. And this little arrow sign here is kind of showing where this narrowing in the artery occurred here. Here's another angle, so you're looking at it from an inferior aspect. But here again, the artery is coming up here, and it should have lots of branches off to the side here, but you can see that there's not any circulation comparatively to the other side that has preserved blood flow. And in this illustration here, this I believe is after they have done some thrombectomy and have tried to reestablish the circulation, or potentially this is after TPA. This is not my own picture, so those are my guesses based on what they're trying to illustrate here. So what's TPA? Okay, TPA is commonly known as the clot buster. It's a medication that's given through an IV, and we give it if the patient is a candidate for it. There's a number of criteria to determine whether one is or is not a candidate for TPA, but we try to give it as soon as possible, typically within 3 hours. Now, there's been some changes in our recommendations, and we can give it in certain patients up to 4.5 hours. But if it's been 4.5 hours since your symptoms started, we can't give it if it's been 5 hours or 6 hours or further on. So that's why going to sleep is a bad idea. So we give this through an IV, and it's a way of breaking up the blood clot so that the blood can, continue on and re-permeate the brain tissue, restoring blood supply and oxygen. So this was developed in 1995. There was a big study in the New England Journal of Medicine that changed care for stroke patients. Before that, there was no treatment except for aspirin. So since then, this has been the mainstay and basically the benchmark that we've practiced neurology and stroke since then. It demonstrated that using IV TPA reduced disability 3 months after the stroke occurred, 30% compared to placebo. So patients who did not receive TPA did 30% worse than the patients who received TPA. It changed medical management. It's now the standard of care, and it only took 8 patients to show that there was benefit. So number needed to treat, which is a term we use in medicine, only 8 patients had to be treated before we saw an improvement. So that's a very impressive statistic. So limitations with TPA, however, again, it has to be given within 3 hours, up to 4.5 hours. You must have a known onset of your symptoms. So the common problem that we run into is a person has nobody who was with them when their symptoms began, or mom or grandma or husband or wife was at home by themselves. Somebody comes home and finds them, and they can't speak to tell you when things began, or perhaps they're unconscious. And so those are conditions where it's very tricky and sometimes dangerous It is dangerous, but it's sometimes impossible to give TPA when we don't know. So having a witness to your stroke or having somebody who can attest to when you were last normal is critical in our decision making. There's absolute contraindications, and there's many of them, but we have a whole list of criteria. But for example, if you've ever had bleeding in your brain, we don't give this medication because it can actually increase your risk of bleeding. There's a 6% increased risk of hemorrhage by giving this medication. However, there's a 33% chance for improvement in recovering disability. So typically most people take their chances with the 6%, but occasionally you get people who say, no, I'm not willing to do that. So what else can we do aside from TPA? Fortunately, things have come even further in the last few years. So now there is the ability to do intra-arterial stroke treatment. IV TPA is given through intravenous mechanism, but there is a capability to give it in the artery that's blocked. But even more exciting is the advent and the standard of care now to extract a thrombus. And a thrombus is essentially the medical term for a clot. So if we see a clot in your artery, we can go in and take it out, which is huge. It's an incredible medical advancement, and it has really good results. So thrombectomy is the term for that. In January of 2015, the New England Journal of Medicine published a study called the Mr. Clean study, and it was a multi-center study throughout the world. The Netherlands was the predominant place for the study, but it showed that there was a profound improvement in stroke symptoms in patients who had thrombectomy. So what they do, as I said, is they go in and they take out the clot. We have 6 hours to do that. So when someone comes to our emergency room, we can still give TPA, and if we see a clot, we can still go in and get the clot. So we give the TPA and we go in to try to retrieve the clot that's blocking the artery. 13.5% improvement was seen in that study, and that was felt to be statistically significant. So in terms of functional independence, it was 32% versus 19% of patients who were independent. So I have another illustration of what is a thrombectomy. I want to show you kind of what they do during this procedure. It's kind of interesting.
Treatment of acute ischemic stroke with clot retrieval device. Ischemic stroke is a condition in which normal blood flow to the brain becomes interrupted. When a clot becomes lodged in one of the arteries that supplies blood to part of the brain, the tissue is deprived of oxygen. Clot removal devices are designed to treat ischemic stroke by removing the blood clot from the artery. The clot removal procedure begins by advancing a guide wire through the blood clot within the artery. A microcatheter is advanced along the guide wire until it is beyond the clot. The guide wire is retracted and the clot retrieval device is advanced through the microcatheter and deployed as the microcatheter is retracted. Once unsheathed, the device expands, pushing the clot to the walls of the artery and immediately restoring partial blood flow. Over the next 2 to 5 minutes, the device becomes embedded in the clot. The clot retrieval device, along with the blood clot and microcatheter, are removed from the body. Blood flow is restored and verified with imaging. The entire procedure typically takes less than an hour.
No, this has become standard of care in the last 2 years, since 2015. So this is another illustration of how profound the blockage can be, and after they take the clot out, how well it reestablishes the circulation. So this was a middle cerebral artery stroke. So all of these blood vessels were completely blocked by this clot that was sitting right there at the branch of the MCA. So that type of stroke would lead to profound disability, meaning drooping of the face, weakness of the arm, inability to speak. So that's a major save for that person. This is a picture of the clot. When it comes out, it's attached to the coil, and they're pretty ugly looking things. Yeah. So who's at risk for a stroke, right? That's how everybody wants to know. Are they a person who should be worried about this for themselves? So 90% of strokes are explained with modifiable risk factors, so things that can be improved upon. 80% of recurrent strokes can be prevented with risk factor control or elimination. Non-modifiable risk factors are things we have no control over. For example, our age, can't help that. We're all doomed to get old. But for 10 years over the age of 55, your stroke risk doubles for men and for women. Gender, men are actually 1.5 or 1.25 times greater risk of having stroke than women. Our hereditary or genetic components are unfortunately what we have no control over. In the race category, blacks tend to be about twice as affected by stroke, or I'm sorry, even more likely to die than whites. And that's inversely proportional to age. Chinese and Japanese also have a high incidence of stroke, even more than heart disease, which I'm not entirely sure why that would be, but that's a known statistic. Hispanics, I've read mixed opinions about that. It's actually thought to be higher than whites as well. But that could be, I think they also have a higher risk of diabetes, so I'm not sure. Diabetes is a strong risk factor. Modifiable risk factors, number one is hypertension. That's the most common modifiable risk factor. Elevated cholesterol, diabetes, tobacco. I would say probably tobacco is up there. It might even be higher than cholesterol. I don't necessarily have these in order. Alcohol consumption is a risk. Physical activity, or lack of activity, I should say. Diet, obesity, even hormone replacement therapy. Estrogen supplements can be associated with strokes. I actually had a patient who wasn't very old, maybe 6 months ago, or maybe it's been longer than that. She's 37 years old and she had a stroke, and I could not find any reason whatsoever why she would have had a stroke. She was not a diabetic, she had no blood pressure, no high blood pressure, no tobacco use. She took birth control pills, and that was the only thing. I mean, I did a huge panel of laboratory studies to find out if she had some clotting disorders, but I couldn't find anything. So estrogen sometimes can do it as well. So if you have hypertension, there are reasonable goals that we try to set for patients to keep from escalating your risk. So if you have hypertension, we try to keep your blood pressure under 140/90. And we want to decrease it at least 5 millimeters from your baseline. 10 millimeters in the systolic number and 5 millimeters in the diastolic number. If you're a diabetic, however, we're even more aggressive. Or if you have chronic kidney disease, we want you under 130/80. If you don't have hypertension, we'd like to keep you under 120/80. That's a normal blood pressure. For cholesterol, we say individuals who have suffered a stroke should have an LDL, which is your bad cholesterol, of less than 70, or 50% lower than what it was when your stroke occurred. In diabetics, hemoglobin A1C of less than 7, which actually I should have updated this a little better. It's since changed since I made this slide that it's actually less than 6. Smoking and tobacco cessation, obviously, that's pretty straightforward. Shouldn't smoke. Smoking increases your risk factors for many things, but certainly stroke. Alcohol consumption. For men, they say 2 or fewer drinks per day, and for women, 1 or fewer. I don't know why that is, but they also say that 1 glass of red wine can actually prevent a stroke. So I don't know what to say about that. That statistic there could go either way. For physical activity, I encourage patients, and the American Stroke Association encourages patients at least 30 minutes of moderate intense physical activity at least 3 times per week. So for people who aren't used to exercising, that's a lot. But when we say moderate intense physical exercise, we say exercise where you feel like you're a bit short of breath, a little winded, you can still have a conversation, but you just feel like you're working a little bit, okay? Diet, we encourage low fat, low sodium. Mediterranean or diabetic type diets are largely encouraged, particularly after a stroke, but before a stroke isn't a bad time to start either if you've got some of these other risk factors that we mentioned. Obesity, we want your goal BMI between 18.5 and 25. AFib is another risk factor. This is a heart condition that is basically when your heart becomes where it starts to beat erratically. So you get an irregular beating of the left atrium, and that leads to inconsistent pumping. And the atrium has little pockets in it. So in those little pockets, if your heart is not pumping properly, you can form little blood clots in those chambers of the heart, and they can circulate out of the heart and into the brain and lead to stroke. So that's kind of the mechanism of that. It affects nearly 10% of patients over the age of 80 have AFib. It's responsible for nearly half of cardioembolic strokes. It usually leads to rather severe strokes and severe disability or death as a result. There's many criteria for who is at risk for AFib and who has AFib. Age, hypertension, diabetes, congestive heart failure, prior strokes or TIAs, sex also. So treating AFib can be somewhat challenging. Many times when we have a patient who we believe has AFib, we have to prove it, okay? So establishing on a cardiac monitor that AFib is present is sometimes challenging because sometimes people don't know they have AFib, they just present with a stroke. So we have to identify who has it. That's why a lot of times after a stroke, we tell you have to go home and wear these annoying cardiac monitors where we have these stickers attached to your heart and the little necklace with the pack on. But we want to get an accurate reading of your heart rhythm to see if you're actually going in and out of it, because sometimes people don't have any symptoms of AFib. When you do have AFib, if we can find it, it changes the course of treatment. So it's really important to figure that out in patients. Carotid artery stenosis or carotid artery narrowing is another strong risk factor. So the large arteries, meaning the carotid arteries, the internal carotid artery, or the middle cerebral artery, or some of the branches off of those, are responsible for 15% of ischemic strokes. So over the last 10 years, there's been quite a bit of improvement in treatment for stenosis of the carotid arteries, and that has reduced secondary occurrence of stroke. So if you have severe symptomatic stenosis, meaning you're having TIA symptoms, we recommend that you go get that fixed. If you have a blockage in your artery that's 70% or greater and you're having symptoms of waxing and waning, weakness, numbness, tingling, speech trouble, typically we say you should go and get that fixed before that leads to a catastrophic event. There's options for what treatments are available, either carotid endarterectomy where they go in and actually open the artery and peel out the plaque from the wall. That's a pretty cool surgery as well. It's pretty interesting. But they also have stenting available now as well, so they don't always have to be so invasive. Although statistically, the carotid endarterectomy in some individuals is a better outcome. In asymptomatic stenosis, meaning if you have blockage but you've never had TIAs or warning symptoms that stroke might occur, we recommend aggressive medical therapy. Excuse me. We do that with medications like antiplatelet therapies, lowering the blood pressure, lowering the cholesterol, improving diet, things like that. So to summarize all of this information, stroke is considered a brain attack, okay? We want you to recognize your symptoms and act quickly. Get help, call 911, go to the emergency room, don't go to sleep, call somebody, tell them something's wrong, have someone come and get you, do whatever you have to do, but get someone's attention so you can get to the emergency room. Modifying your risk factors by meeting with your primary care physician and figuring out, is my blood pressure well enough controlled? How is my diabetic management going? What's my cholesterol level? Things like that. Even if you have a family history of stroke and you've had an evaluation, these are things that your primary care physician can talk with you about and hopefully try to prevent them. That's it in terms of my formal presentation, but I certainly have lots of time for questions if anybody does have questions for me.